Hello everybody. We are here to discuss the very recent exam that has just gone by, AIIMS November 2018, and I'll be focusing on the questions from dermatology. Skin questions, barely 6-7 questions, nothing much, but these 6-7 questions are also the ones which will help you in gaining the edge because they are not very easy. They are decent level questions. If you do them well, that's your job done as far as dermatology is concerned. So yes, moving on to the first question for the day. These are all recall based questions. Patient with a 1-year history of nodulocystic acne as shown in the figure, the drug of choice. They are giving you everything that is required in the text only. The image is not important for this because they are giving you what is the main thing. It's a nodulocystic acne. Right? So what is the drug of choice of nodulocystic acne? Image is just adding to it. See, these are the nodules. These are the nodules. So by chance, had they not written in the text that it is a nodulocystic acne, then also you have to identify in the image. Then also you have to identify in the image as to what it is. So in the image also you see these big lesions on the chin, on the cheek. These are your nodules, the cystic lesions of nodulocystic acne, which is your grade 4 acne. So as far as this is concerned, we have a clinical staging which helps us in deciding the treatment also. Stage 1, 2, 3 and 4. So these are the 4 clinical stages of acne. What does grade 1 contain? Grade 1 contains only comedones. Grade 2 has more of papules. 3 has pustules and 4 has your nodulocystic lesions, right? So these are the 4 clinical stages or grades of acne. Now, how does the treatment differ? For a simple comedonal acne, my treatment of choice would be a topical retinoid. Okay, that would be my treatment of choice. For papules, it will be a topical retinoid plus topical antibiotic. Pustule will be a topical retinoid plus oral antibiotic, and nodulocystic will be only oral retinoid. That is how my treatment goes upon in different stages of acne. Now, what is the topical retinoid that I have here? My main options here are adapalene and tretinoin, right? Topical retinoid is done. The topical antibiotic, my best options here are clindamycin, then topical azithromycin is there, and you have topical nadifloxacin, topical dapsone. So these are my options for topical antibiotic. In the oral antibiotic, my options are tetracyclines like doxy, mino and limecycline. Okay, doxy, mino and limecycline. Then I have topical macrolides where I have azithromycin and clarithromycin. And the next option that I have is topical oral clindamycin. In the oral retinoids, my answer is, and my only option is, isotretinoin 1 mg per kg per day. So these are the major treatment options for acne depending upon the clinical staging, and these are very important questions. Why? Because they will ask you as per the grade, then they will ask you the side effects of these treatment. important is also not just the treatment, but their side effects as well. As far as tretinoin is concerned, the most common side effect they will ask you, most common side effect is irritation. You know, it is a retinoid, you apply on it, I'll tell the patient that it is common to have slight burning, stinging, but your face might turn red, scaling. If that happens, stop the treatment, come back to me. So that is how commonly tretinoin causes it, that I have to tell every patient of mine. So most common side effect is irritation, and that is a question. Then, as far as topical antibiotics are concerned, the question here is that which is the drug of choice in antibiotic resistant acne. In case an acne doesn't respond to topical antibiotics, what will you give? Then you give topical benzyl peroxide. So that is the drug of choice in a topical antibiotic resistant acne. Okay? Now, they will ask you the side effects of minocycline. Very important. Side effects of minocycline. Minocycline, what can it do? Minocycline can cause 1, drug-induced lupus. 2, it can cause pigmentation. So if there is a clinical situation where a 20-year-old girl was taking treatment for some reddish papillary lesions on her bilateral cheeks, a few months into the treatment she developed bluish black pigmentation in the scars as well as on the normal skin. What is the medicine that she was taking? The medicine that she was taking is minocycline. So a very, very important side effect of minocycline is drug-induced pigmentation. Then what they will ask you is that you can give macrolides in pregnancy. They are safe in pregnancy. Rest of the other antibiotics like doxy, mino, lime, they are not to be given in a pregnant patient. There is a risk of discoloration of the teeth. So tetracyclines are contraindicated in pregnancy, but macrolides can be given safely in a pregnant patient. Moving on to the 4th grade. The 4th grade is a oral retinoid. Oral retinoid, which is your isotretinoin at a dose of 1 mg per kg per day. This is my drug of choice in grade 4 nodulocystic acne. Okay, cumulative dose is around 120 to 150 mg per kg. So if I have a patient of acne, I have to give her in total 120 mg to 150 mg per kg. Means a 60 kg patient into 120 mg is to be the total amount of dose that I will give her in order to treat this nodulocystic acne before I stop it. So you have to remember the oral retinoid, which is isotretinoin, not acitretin, not etretinate. No, only isotretinoin for acne. Cumulative dose. Then you also have to remember that this is a pregnancy category X drug. This is absolutely not to be given in a pregnant patient. If you give it in a woman of reproductive age group, double contraceptive measures, hormonal and barrier, and monthly UPT negative. So you have to take these precautions when you give isotretinoin in a patient who is a woman of reproductive age group, double contraceptive, monthly UPT negative, because it is pregnancy category X. Even retinoids we don't give, although they are B and C, but we still don't give. We don't give tetracyclines. So in a pregnant patient, is this chart clear to everyone? Yes? If they ask you what can be given in a pregnant patient with acne, then you can give benzyl peroxide and you can give macrolides. These are the only 2 things that you can give in a pregnant patient with acne. Clear? And with isotretinoin, there are 2 other questions which you need to remember. 1 is most common side effect. 2 is most important side effect. So most common side effect is dry, chapped lips, which is cheilitis. Most important side effect is teratogenicity. Clear to everyone? All these are important questions. Cheilitis is the most common side effect. A patient who is taking isotretinoin will have dry, chapped lips. It is so common that if I am prescribing isotretinoin to a patient, I will give her Vaseline lip balm also, because this is going to happen. So this is the most common side effect. However, most important side effect remains teratogenicity, pregnancy category X, not to be given in a pregnant patient. Clear to everyone? Good. So, a patient with 1 year history of painful nodular cystic acne, what will be the drug of choice? The drug of choice will be oral isotretinoin. Clear? Yes? Good. Now we move to the next question. This again an image-based question. This just tells you how important images are. They will put it in every question that they ask in dermatology, in every exam. Be very vigilant on your approach to these image-based questions, as well as your OPD postings. So, blister pack is shown. Where is it used? I am sure all of you can answer that. This is a relatively easy question. See, blister packs are used in leprosy treatment, they are used in TB treatment, they are used in STD, they are used in HIV. In every 4 of these illnesses, blister packs are given to the patient, right? So, the question here is asking you to identify this particular blister pack where that is used, right? If a patient with STD comes to me, I will give her the kit. We have the NACO kits, the genital ulcer, the genital discharge, bubo, cervical discharge kit. I have kits. I will give that kit to the patient. A TB patient goes to the RNTCP center, he will get a blister pack which he has to consume. HIV patient also gets proper bottles of ART. Leprosy patient also gets kits. So all these 4 will get it, but you identify this kit. Now, this kit has 3 medicines in it. You can make out. One are these long ones, one is this white, and one is this short one. So identify that this has 3 medicines. This is separate, this is separate. So it has a monthly medicine plus it has a daily dose. So this is what this image tells you. One is white, one is red, that's it. So which of these 4 has such a kit where you give monthly doses to the patient and you give them daily treatment? That is only seen in leprosy. So that will help you identify this question here. So this is the leprosy treatment. What MB, MDT, adult. MB, MDT, adult. Okay? This is what you will see here. What does it show you? This shows you monthly rifampicin 600 mg, clofazimine 300 mg, and dapsone 100 mg. So this is what it is showing you. And then you have this clofazimine and dapsone daily, which the patient will have. MBMDT for adult to be given for 12 months in multibacillary leprosy. I have an image to show you. Any question that you get, you not only have to remember the kit, you also have to remember the color. Okay, you have to remember the color also. Just one thing you remember, in leprosy, depending it is multibacillary MDT or it is paucibacillary MDT. In multibacillary MDT, there will be monthly rifampicin plus clofazimine plus dapsone, and it will be daily clofazimine plus dapsone to be given for 12 months. In PBMDT, it will be monthly rifampicin plus dapsone, while daily will be only dapsone, to be given for 6 months. So this is what you have to remember. Remember the color of the kit. This is, both of these are there in adult and child. Adult and child. So remember this, that in this only daily dapsone is given in PBMDT. Now we come back to the kit. Look at this kit. This is the MDT regimen. This is for adult, this is for child. So a green is PB adult, red is MB adult, and similarly a blue is PB child, and orange is MB child. So just remember the color of the kits. Okay, remember the color of the kits. That can be asked to you. Important in PSM also, important in pharmacology and dermatology. Everywhere they can ask you this. Green, red, blue, orange. Okay? Clear? So this is actually rag, and this is BCO. Just remember these two things, rag and BCO. You will not forget it. Clear to you? Yes? Good. So should we move to the next question? Next question is actually one, you can call this as a physiology question, you can call it as a dermatology question, whatever. This is a question on the tactile receptors. Meissner's corpuscles are present in which layer of the skin? So what are these Meissner's corpuscles? These are actually tactile receptors for light touch, and they are rapidly transmitting. So they are rapidly transmitting, therefore light touch, tactile receptors, especially in the non-hairy skin. There are 4 major tactile receptors in the skin: Meissner's, Ruffini's, Pacini's, and Merkel cells. So these are the 4 main tactile receptors in the skin: Merkel, Meissner's, Ruffini's, and Pacini's. So these are the 4 main. You have to remember their location, their function. This question is focusing on Meissner's corpuscles. These are the tactile receptors for light touch in non-hairy skin, most dense in your finger pads, where you actually have to touch. So these are most dense in your finger pads. Where are they located? They are present since they are present for light touch, they cannot be very deep in the skin, right? If something, even if you don't remember this thing, just put your common sense that Meissner's is for light touch. If I have to take something which is light touch, it cannot be very deep in the skin. If it is very deep in the skin, then it is not for light touch, then it will be for deeper touch, for pressure sensation, that will be deeper. A light touch thing has to be more superficial in the skin. This is immediately beneath the epidermis. So this is my epidermis, like this. These are present here. Okay, and that is how their nerves go. So these are present immediately and this is of course my skin running like this. So where are these present? These are present in the papillary dermis. Something that is sensing a light touch has to be superficial in the skin, otherwise it is not going to do its job. So this is present in the papillary dermis. Clear? In stratum basale you have the Merkel cells. Stratum basale you have the Merkel cells. Okay? Clear to everyone? Yes? Good. So Meissner's corpuscles are in the papillary dermis, tactile receptors, light touch, non-hairy skin. Okay? Good. Should we move to the next one? Yes. This is again an image-based question. See how commonly they are asking you images. Patient with rashes in the groin as shown in the image, which of the following cannot be the cause? Here they are not asking you to identify, even if you identify, good. They are asking you simple, basic mycology. Basic mycology. This could actually just pass off as a microbiology question also. What do you see in the image here? You see that this is a thing which is affecting the groin. Then the lesions are red. They are scaly with irregular but well-defined margins. So, had there been history, these would have been itchy. What is the diagnosis? Tell me. The diagnosis is tinea cruris. Diagnosis is tinea cruris, also called as dhobi itch or jock itch. You get questions on these synonyms also. Dhobi itch is a question, jock itch is a question, groin is a question, tinea, they would have even asked you to identify. If they had asked you for that, then the answer is tinea cruris. Now, what do they want you to tell? This is basically when you talk about mycology, you have these dermatophytes, non-dermatophytes, and the yeast. In the dermatophytes, the main ones that you have are these ones. Trichophyton genera, epidermophyton, and microsporum. These are the three main important dermatophytes. Now, what is it that you have to remember? Trichophyton can involve hair plus skin plus nail. Epidermophyton can involve only skin plus nail. Microsporum only hair plus skin. So this is the major distribution, and these cause your mainly the superficial infections. Non-dermatophytes, these mainly cause deeper subcutaneous infections, and they can cause nail involvement. So they don't cause your superficial cutaneous infections, they will cause deeper infections. Yeast can involve skin plus nail, and skin it can involve both superficial and deep. Correct? Clear to everyone? So dermatophytes cause only superficial skin infections because they are keratinophilic. So they can only involve the superficial skin, cause all those tenias, capitis, corporus, cruris, barbi, fasciae, tinea capitis. All of these will be caused by mainly dermatophytes. NDMs will cause deeper subcutaneous mycosis, and they can also cause nail involvement. Yeast will cause all types of infections, superficial, deep, and nail. This is a very important diagram. Please remember, you get questions on these. These are all questions. This is a question. This is a question. These are all important topics. Remember, just go through it once more. Only then will I change. So now, when we come back to this image, patient with rashes in the groin region, we diagnose that this is tinea cruris. Tinea cruris is a superficial dermatophytic infection. This can cause it, this can cause it, this can cause it, but this cannot cause this. This will only cause the deeper infections. Okay? These three will cause a superficial infection. Clear to everyone? So the answer here is aspergillus. I hope there is no doubt in this. This is simple mycology. Microsporum, epidermophyton, and trichophyton. Clear? Yes. Now the next question is this. Just go through it. Rashes all over the body with 30% BSA involvement. What could be the trigger factor? This is a very vague question since it is based on recall. I cannot be completely sure of what it is asking, okay? Because even a viral infection can cause a rash which is involving the entire body. Bacterial infection can also cause a rash which is involving the entire body, like scarlet fever. Viral, you have all those exanthems. Bacterial is scarlet, idiopathic can be there, drug-induced can be there. So this is basically a vague question, not very clear as to what it is actually asking you. What the original question must have been, the original question must have been a purpuric rash with peeling of skin more than 30% area, along with maybe mucosal ulcerations with skin tenderness. This is what the original question must have been. So tell me, what am I describing here? A purpuric rash with peeling of skin in sheets involving more than 30% body surface area, with mucosal ulceration, which is stomatitis, skin tenderness. What is this that we are discussing? We are discussing TEN, which is toxic epidermal necrolysis, which is actually a drug-induced eruption. So this 30% gives me that hint that they are discussing TEN, because in no other type of eruption do we actually categorize the body surface area involved. Okay, so that gives me this hint that they are talking about this. When we talk about drug-induced SJS10, this is what we discuss. If it is SJS, if it is SJS 10 complex, or it is 10. This is less than 10% BSA. This is 10 to 30% BSA, and this is more than 30% area involved. So if this particular cutoff of 30% is concerned, then it is only this that they can be discussing, and these are drug induced. Okay, viral rashes can involve any surface area, bacterial rashes can involve any surface area. So that is not what the question is asking. The question is asking you about TEN. Since this is a recall based question, there can always be errors in recalling. I am telling you what the original question must have been. That must have been drug induced toxic epidermal necrolysis. Just remember the scoring that we do here. Scoring we do is the Scotton scoring. Okay, that is the scoring that you use. Treatment is immediate cessation of the drug. Clear to everyone? Any doubts you can still get back to me, but for now this is the best interpretation of the question with the best answer. Moving to the 6th question in dermatology in this exam. This is an image based question. Mother presents with pearly white lesions on the forehead. So this is a mother who is presented with some lesions, but the image that they have given you is of the 2-year-old daughter who has similar lesions on the chin. What could be the cause? So what do you see in the image here? In the image, what you see? You see these pearly white dome-shaped papules. You are not seeing the central umbilication that you can obviously imagine with central umbilication. And what is this? This in this line, this in this line. What is this? This is actually pseudo cornerization. Okay, so see this. I'll remove this. See it again. See this. This 1, 2, 3 lesions in a line. Here also they are in a line, and here also they are actually in a line. So this is pseudo cornerization, which is appearance of lesions at the sites of scratching. Pseudo cornerization. What is the diagnosis? Tell me the diagnosis. Typical description, typical clinical image with the hint of pseudocornerization. You cannot go wrong in this. The answer to this is molluscum contagiosum. You cannot go wrong with this. It is a very typical clinical image. Very typical clinical image showing you pseudocornerization. The question tells you that these are pearly white papules. They also tell you that it is there in the mother and the child, because these is a viral infection which spreads by touch. So if it spreads by touch, there can be a history of similar lesions in siblings, in other members of the family, in friends. Okay, so it gives you that history that it's a viral infection which is spreading by touch, giving you the typical clinical description, the typical clinical image. There has to be absolutely no doubt in the diagnosis of molluscum contagiosum. Now, what is this caused by? What is it caused by? It is caused by molluscum pox virus, which is a double-stranded DNA virus, and it is also the largest known virus. Inclusion bodies are your Henderson, Peterson bodies. Clear? This is what you have to remember in the microbiology of the virus. Molluscum pox, dsDNA, largest, and even the inclusion bodies are the largest. Central umbilication, don't forget, and it can self-resolve in 6 to 9 months, but sometimes you might need to give topical treatments. That is separate. So this is what you have to remember about molluscum contagiosum. Typical clinical feature, virus, self-resolved, otherwise you give topical treatments like TCA, needle extirpation, KOH, cautery, cryotherapy. That is the treatment. So the answer here is pox virus, mollusky pox virus, pox viridae family, dsDNA, largest, Henderson-Peterson bodies, pseudocochlearization. Do not forget the pseudocochlearization. Where else do you see pseudocochlearization? You see pseudocochlearization in warts also. HPV-induced warts. You see pseudocochlearization there also. And where do you see true cochlearization? True cochlearization is seen in psoriasis, vitiligo, lichen planus. That is true cochlearization. This is pseudocochlearization because this happens due to inoculation of lesions along the site of scratch. It is not coming from within the body. This is due to exogenous inoculation. Pseudocochlearization. Clear? All questions of MC now you can deal with this knowledge. Next question, again an image-based question, and this is exactly how they gave the question last year also. This is actually a repeat. Last year also they had given a histopath image, identify the disorder. This year also they have done the same thing, image, identify the disorder. There is no text, there is nothing, straight away identification. This is why I have been telling in all the discussions that some important disorders, those images you should be well aware of. There is absolutely no doubt in that. So, what is this image telling you? This image, look at the image. Identify that yes, it's a skin biopsy. Take it there, you don't know, it's a dermatology question. There it's all mixed. So there, first of all, the first thing has to be identified that this is a skin biopsy. Okay, it's a skin biopsy. This is your epidermis. This is your dermis. Okay, so identify that this is a skin biopsy first of all. Then look for the pathology. What is the problem in the biopsy? Look from far, what do you see? You see this cleft, means you see the separation of the layers, right? That is the first thing that you notice in it. It's a skin biopsy. Problem is that there is a separation between the layers. Now, identify the separation. Where is the split? That is the most important thing. Where is the split? This, as I told you, is the epidermis. This is the dermis. This is your stratum basale. So this is stratum basale. This is stratum corneum. Okay? Stratum basale, stratum corneum. This is the cleft. Now, the two important disorders which have an intra-epidermal splitting, those are pemphigus vulgaris or pemphigus foliaceus. Okay, these are the two disorders which have your intraepidermal splint. So pemphigus vulgaris, pemphigus foliaceus. In pemphigus vulgaris, it is mainly DSG3 plus 1. This is DSG1 only. So the split here is in the lower layers. It's a supra-basal split with the row of tombstone appearance of basal cells, which means that the cells have also separated from each other. That is the cleft. So this is the image of pemphigus vulgaris. Here it is DSG1, this is in the upper layers. So this is a subcorneal split. This is your stratum corneum. This will be the cleft. This will be the other cell, and this will be your stratum basale here. So Here it's a deeper split, here it is more of a superficial split. Clear to everyone? Remember the subcorneal in this one and suprabasal in this one. You remember this, you see the image, you will identify. So now we get back to the image. In this image, what do you see? Here, you see the stratum basale running. The cleft is immediately above the stratum basale. So this is a suprabasal split. Basal, you see the stratum corneum, you see the stratum granulosum, you see the stratum spinosum. Split here is suprabasal, immediately above the basal layer. Where is that seen? That is seen in pemphigus. Clear to everyone? Yes? Clear? In lepromatous leprosy, what would we see? We will see foamy macrophages, which are also called as Virchow cells, plus you will see a zone which is the Gren zone. Here you will see epidermal necrosis. Here you will see suprabasal split plus tombstone appearance. Here you will see intraepidermal lymphocytes, which is also called as your Pottier's abscesses. Clear to everyone? This is the histopath of the other three options, while that of the image clearly, without any doubt, matches that of pemphigus vulgaris. I hope all of you have understood. Nothing difficult in this. Pemphigus vulgaris was asked last time also. This is a stat repeat, and it's an easy one. There is no doubt in that. I just have this image to show you. This, see, that I was telling you, this is the stratum basale running, stratum spinosum, corneum. The split is subcorneal. Here, this is the basal running with the entire epidermis above it. This is a suprabasal. This is subcorneal. While you come to this image, this is also commonly asked, so don't think that they will not ask you this. Here, as you see, that this is stratum basale, spinosum, granulosum, corneum. This is the entire epidermis and the dermis. The cleft here is subepidermal. It is below the level of the epidermis. So identify the level of the split. That is the first thing to do, and only then can you come to the disorder. It is in the epidermis, below the epidermis. If it is in the epidermis, what is the level? If it is below the epidermis, then most commonly they will ask you bullous pemphigoid, because there is not much difference in the histopath of the subepidermal disorders. So the stat classic one is the bullous pemphigoid. See that the entire epidermis is above it, lesion is below the epidermis, and then the dermis. So this is a subepidermal split. I will remove this from here so that you can have a clear one. This is a subepidermal split. So the split is below the epidermis. This is bullous pemphigoid. Clear to everyone? There is just one more thing that they will ask you, this. If such an image is given, see that again epidermis is above it. See this, epidermis is above. So where is the level of the split? The level of the split here is also subepidermal. Okay? Level of the split here is also subepidermal, but it is concentrated in the papillary dermis. Subepidermal, papillary lesions, and you see these neutrophilic abscesses in the papillae. So what is this? This is classical of dermatitis herpetiformis. Papillary neutrophilic abscesses, granular IgA, and without any doubt dermatitis herpetiformis. Clear to everyone? This is not just a simple split that they've shown. They've shown you that the split is here in the papilla. So focus on that point, what they are telling you. This is dermatitis herpetiformis. Association is with celiac disease, which is gluten sensitive enteropathy. Gluten cessation is an important part along with oral steroids, dapsone, and always remember mucosa is never involved in DH. What is the tissue transglutaminase is the antigen. Any doubts in this, you can always get back to me. This is my email ID. I hope I have been clear. Still, in case you have any doubts, get back to me. I'll be more than keen to help, especially with exams around the corner. Okay? Thank you so much. All the best. Do well.